Hey everyone, welcome back to the Healthy, Wealthy, and Smart podcast channel. I am your host, Dr. Karen Litzy, physical therapist. And before we go on, don't forget to hit that subscribe button. Make sure you don't miss an episode. Now, today we're talking about something near and dear to my heart, and that is gluteal tendinopathy, which I suffered from about a year and a half ago, 2 years ago. And man, was that painful. So I love talking about this. I love treating people with gluteal tendinopathy. And today I have one of the best practitioners and researchers on this very subject. So I'm joined by Dr. Alison Grimaldi to discuss diagnosing and rehabilitating a gluteal tendinopathy. A little bit more about Dr. Grimaldi. She's an Australian sports physiotherapist and the practice principal of Physiotech Physiotherapy in Brisbane, Australia, with over 30 years of clinical experience and special interest in the management of hip, groin, and pelvic pain. She has a Bachelor of Physiotherapy, Masters of Sports Physiotherapy, and a PhD through the University of Queensland in Australia. Allison was a key investigator on the multi-center LEAP, that's capital L-E-A-P, all capital, randomized clinical trial comparing the effects of treatment for gluteal tendinopathy. She has had involvement in research for over 20 years and continues her research interests as an adjunct senior research fellow at the University of Queensland and in collaborative international research. She has contributed to 3 leading clinical texts, conducted over 100 clinical workshops worldwide, and presented over 50 keynotes, invited or podium conference presentation. Allison also runs a hip academy with online learning and live mentoring, which you can find at Dr. Alison Grimaldi, all one word, .com. So I'm really happy to have Dr. Grimaldi on the show. She really breaks down how to evaluate, how to treat it. It's awesome. So I learned so much, and I'm really excited for all of you to learn so much from her as well. So enjoy today's episode. Hi, Allison. Welcome to the podcast. It's such an honor to have you on. So thank you so much.
Thanks so much for having me, Karen. It's great to be here with you today.
Yes, and soon in a couple of months, you'll be here in New York City. We'll get to that a little bit later in the podcast. So if people are in the United States and they want to see you in person, we'll talk about when you're going to be here in New York City with 2 workshops. So it's really exciting. But people have to wait for that good stuff. But before we get to that, I'm really excited today to talk about gluteal tendinopathy, near and dear to me, as I suffered from that. I think it was not last year, but the year before, maybe. Yeah, I think it might have been the year before. And boy, oh boy, is that uncomfortably painful. So let's start with definitions. What is a gluteal tendinopathy?
Well, tendinopathy in general just refers to persistent tendon pain and loss of function related to some sort of mechanical loading. So gluteal tendinopathy is about painful gluteal tendons, and that's generally the gluteus medius and or minimus tendons. So it can be either of those. And related to loss of function, which is usually around single leg weight bearing tasks like walking, stair climbing, standing on one leg to dress. And of course, it's very tender to touch these tendons. And so when you lie on your side, it tends to be painful. So that's generally how we see the presentation of gluteal tendinopathy.
And here's, of course, the loaded question is, what causes it?
Well, previously it's been referred to as trochanteric bursitis, and back then it was thought to be an inflammatory condition of the trochanteric bursa. That hasn't really panned out to be, the case, or particularly not the whole case. We rarely see change in the tendon change in the bursa without changing the tendon. So it's actually very rare to have isolated trochanteric bursitis. And so the predominant issue seems to be in the tendon. So why does this tendon become painful? The condition seems to be more a degenerative condition rather than, an acute inflammatory condition. But usually when the pain comes out, it's related to some sort of change in mechanical load. And so that might be a slip or a fall, Or it might be that someone's increased their activity levels. And we see this very commonly in perimenopausal or postmenopausal women that might have increased their activity levels to, deal with weight gain and things like that. And so that rapid increase in activity level can, really affect those tendons, and the tendons become painful. That can also happen with younger people, particularly with things like running, suddenly increasing running distance or hill running, things that are more challenging for the glutes and those tendons. And sometimes it can just be that there hasn't been a really significant shift in load, but just over time, the person might be becoming weaker and weaker from sedentary activities or some sort of other injury or illness that's not been allowing them to load their tendons normally. And then those tendons reduce the capacity for load so far that even the normal activities of daily living will represent overload, if you like, and then pain will come out. So they're the most common scenarios we see.
And how prevalent is it?
So most common in postmenopausal women. And there it's really highly prevalent. So around 1 in 4 women will suffer with gluteal tendinopathy in that peri-postmenopausal period. It does occur in males as well, but in that same age group, usually only about 1 in 11 males. We don't have the stats, if you like, in younger groups, but as I mentioned, we do see it in younger runners, people involved in maybe going to the gym and doing, step type classes, things like that, particularly if they're unaccustomed to it and then suddenly join step classes and start doing a lot more activity. And we do see it a bit in clinic, like with females, particularly after having babies. Because in that sort of postpartum period, often there's a bit of a, lack of a reduction in capacity. And then in the effort to, get back the pre-baby body, increase that activity level, and perhaps, not having good enough control around their pelvis. And then they might develop the condition at that stage as well.
Yeah, that all makes perfect sense. And I'm nodding because I'm like, yep, that was me. So let's talk about what kind of impact it has on people's lives. So I had a diagnosis of gluteal tendinopathy, like I said, about 2 years ago. And I could tell you the impact it had on my life. I couldn't stand for more than 4 or 5 minutes. And so I'm a physical therapist. I see patients in their home, so I have to walk. I could walk quickly. That was much more comfortable, and you can explain why that is. Walking slowly, or what I call like museum walking, when you're sort of meandering, out of the question. And going up and down subway steps, horrible. I mean, it affected everything I did every single day. Unless I was laying down, even sitting, and not lying on my side, laying on my back or lying on my left side. Like even sitting in certain chairs was not comfortable. So that was my experience. So what have you seen in the people that you treat in clinic? What kind of impact does it have on their lives?
So it can have really substantial impacts. Actually, Angie Fearon's work showed that the impact on quality of life is equal to that of people with advanced hip osteoarthritis. So it is a really impactful. The biggest impacts seem to be on sleep and on physical activity related to standing and moving. And, as you mentioned, walking is often painful or sustained standing, and particularly the position that you're standing in can have a big impact in terms of where you're loading the tendons. So positions where you're, maybe sliding to the side a little bit, or even just translating the pelvis forward a bit will also sort of load the more anterior aspects of those tendons. But the meandering versus faster walking, again, it depends how you're walking, but faster walking, you might have gone to perhaps a shorter stride length, more like a scurry. And I'll often say that to my patients. If you're in a hurry, scurry, don't stride, because long strides, you tend to get higher impact forces when your heel hits the ground, which impacts back up at the hip. But also, if you've got those longer, slower strides, if you like, your pelvis tends to have more time to translate laterally and dip down. And we know that lateral translation and lateral tilting really increases the compression of the tendons at the side of the hip. So if we think about the iliotibial band coming from the pelvis and running down the side of the hip there over the greater trochanter, we have our gluteus medius and minimus tendons joining into the side of the greater trochanter there. So they don't just join into the top, they join over the outer side of the greater trochanter. So when the pelvis shifts or drops into a position of adduction, then we get this wrapping around of the ITB around the greater trochanter. And that causes compression, and compression in itself isn't dangerous, but if you've got a painful tendon and you're compressing it, that tends to make it more painful. And potentially compression is one of the factors that can contribute to the development of gluteal tendinopathy, but if it's often a multifactorial situation. But that's why walking and standing on one leg, and particularly if you're weak in the hip abductors, then we see people tending to shift their pelvis and drop into that position of compression. Sitting can be problematic, because particularly if you're sitting with knees crossed, again, I say to my patients, anywhere where your knees are, towards the midline or across your body, or if you're standing, if your hip is out to the side, those sort of positions both wind up that iliotibial band and can make the tendon grumpy. So we don't want to make people, crazily fearful about, positions and postures and things like that, but it's a cumulative thing. And actually we find patients find this really empowering, because if they can understand what things irritate the condition, then they've got great power over altering that and getting this thing under control. So in sitting, legs crossed, again, that's sort of winding up those tendons, and often in deeper chairs as well. So sometimes sitting in a car or a deep lounge, particularly with knees crossed. But even in deep lounges, probably that has to do with the fact that the iliotibial band joins into the gluteal fascia and up into the thoracodorsal fascia. And so higher hip flexion will, wind up all that. And so that potentially increases that compressive load as well. Yeah, so those are the typical things that we see people struggling with, and those have big impacts.
Yep. And I will also add, going to a theater, going to the opera, those seats that kind of fold down and the ones I mean,
That's
like
right.
this.
Yeah.
So painful. Can't even, I remember going to the opera, and I think I lasted for until, I don't even know if I made it to first intermission. I was like, I got to go.
Yeah.
I just couldn't sit any longer. Yeah.
No, that's right. That can be a real problem, because those seats, again, tend to slope backwards to the back. So we encourage our patients, during that painful period, to take a wedge cushion with them. Or some of the theatres actually have cushions that are available, like for children. I'm not sure, like outside the doors, sometimes you'll see a whole stack of cushions. So it's just grab one of those, stick them under your bottom.
Right.
So just you're a little higher.
Right. Oh, that makes perfect sense. And now I think we've covered a little bit, but if you want to synthesize this down, how would a physical therapist or doctor recognize a gluteal tendinopathy? I think we covered a lot of it, but if you want to sort of give it the I don't want to say bullet point, because I don't think that's quite what we're looking for, but a condensed version.
Yeah, great. Well, it's probably good to look at it in terms of patient interview features and physical exam features. So in the patient interview, you're looking for patients who report pain right over that greater trochanter. So we're looking for lateral hip pain over the greater trochanter. They might also have pain that extends down the lateral thigh, and sometimes it does even go just below the knee into the upper shin. And probably because some of that pain might be related to some change we also see in the iliotibial band. So we might actually have an associated ITB fasciopathy, if you like. So that's quite common. But the pain over the greater trochanter is really important because we see so many people being diagnosed on imaging, even though their pain might be somewhere near, their sacroiliac joint or the front of their hip. That's not a clinical presentation of gluteal tendinopathy. So patient interview, area of pain is really important. And then the aggravating factors give you really good clues in that patient interview. So I have a lot of trouble, sleeping at night, but then we need to ask a little bit more questions about that. What position is painful and where exactly is it painful? So sleeping on my side. Okay, so that might be tendon, might also be joint. So you want to tease that out. And is it pain directly over that bone or more general ache somewhere in your hip? Okay, so we're looking for pain, tenderness over that bone when you lie on your side. And that pain can be lying on either side, because even when they're lying on their unaffected hip, if the top knee is hanging down, it's still compression. It tends to irritate them. So those are big things. And then it's everyday things that we've already talked about. So single leg standing tasks. So standing to dress, stair climbing is a big one, walking, particularly up hills or uneven surfaces as well. So those are the key patient interview features. And so then we've already got this thought in our mind, well, this patient might have gluteal tendinopathy, go into the physical exam. So one of the first things that you might do in terms of specific tests for gluteal tendinopathy is just get them to stand on one leg. So as part of the LEAP trial, we had a look at which clinical tests might be most useful in the diagnosis of gluteal tendinopathy, and the sustained single leg stance test showed to be one of the most useful tests. So that's basically getting the patient to stand on one leg, their side onto a wall, and they put just one finger against the wall just for some balance. So we're not testing balance. And then they're standing there for up to 30 seconds. So if they're painful in the first 5 seconds, of course, you don't need to get them to stand there in pain.
You don't have to torture them for the next 25.
Yep, that's right. The test is positive, and it's that's the end of the test. But some people, it might take them, like the milder presentations, it might be 10 or 15 seconds until they get that pain. So you might miss them if you just get them to stand on one leg for a few seconds. So we want to do that sustained, hold and see what happens with that sustained loading on the tendon. Then tests on the bed that we generally use. We use the hip flexion adduction external rotation test that we used in the LEAP trial, and that is effectively hip flexion 90 degrees, full adduction of the hip, and then full external rotation. So we're winding up the hip into a position where we've got those tendons passively, compressed around the greater trochanter. But the test is even more useful if you then add an active element. So in that position, we get the patient to resist against a further external rotation force. So they're doing isometric internal rotation. And so adding that compression to the active tensile load seems to be most useful in getting a positive there. And some listeners might be thinking, oh, why are you doing internal rotation? Isn't the glute med an external rotator? But all of the portions of glute med and glute min at 90 degrees of hip flexion are actually internal rotators now. Okay, so we're loading all of those portions in that position. So we use the fader test. The other test that can be useful is an test of adduction, and that is in side lying. So effectively the modified Ober's test. So put the side lying diagonally across the bed, lower that straight leg right down into end range adduction. Again, we do a 2-part test. We do that passive provocation first, just pushing them into that end range. Need to make sure we stabilize the pelvis there. So we're getting that iliotibial band sort of wrapping over the greater trochanter. Is it painful there? But again, we found it was most useful if we added an active component. So in that position, we get them to resist a further adducting force. So they are doing an isometric abduction. And again, the compression and the active load tends to make the test more useful. We also usually look at Faber test,
Mhm.
so flexion, abduction, external rotation, also referred to as Patrick's test. That test in our assessment showed to be one of the least useful, but Angie Fearon's work showed that it was useful in differentiating between arthritis and gluteal tendinopathy, because if we've got isolated gluteal tendinopathy, we don't see as much, change in range
Right.
in that Faber test. And then, of course, the cardinal sign perhaps is tenderness on palpation of the greater trochanter.
Right.
So we want them to be tender on palpation, but it's important to realize, though, that that test is more useful for ruling out gluteal tendinopathy than for ruling in gluteal tendinopathy. And all that means is that a lot of people are a bit tender on their greater trochanter.
Right.
It doesn't necessarily mean they definitely have gluteal tendinopathy. But if they're completely non-tender, you probably need to be considering other diagnoses. So it's the combination of the palpation and the other physical tests that will help us get the best likelihood of a true diagnosis.
Right. And is it, if one test out of that group is positive, two tests, is if there's no tenderness and one test is positive, what are we thinking then?
Sure. So for the LEAP trial, for getting people into the trial as a clinical screening, we used a clinical diagnosis that was a positive palpation, so they must be tender on the greater trochanter, and at least one positive test in the other physical tests. In clinical practice, I think you'd find that it's quite quick to do the test battery, and I think you'd find that the more positive tests, you might be, more confident in your
Right.
diagnosis.
Right. Yeah. I remember when you're saying like the palpation, like for me, it wasn't like, I don't know, it might be a little tender. I was just like,
Yeah, that's
that's
right.
it.
So some studies call it the jump sign.
Yeah. I was
And
like, okay, never do that again.
that's right. And I call it the eyes widening
Yeah.
sign.
Yeah.
So when you're doing these tests on patients, you're always watching their face. And often you'll see these eyes widening. You go, yeah, that's a positive.
There it is. That's why I'm
There it
like, okay, that's it. All right, moving on.
is.
Because it is true. Like some people around the greater trochanter and other parts of the body, like some people just don't like someone poking them.
That's right.
Yeah. So but there's a difference between that and, like you said, the eye is wide open and the the sharp inhalation of breath and the like, oh my god, never do that to me again, are you a crazy person look.
That's the one. Yeah.
That's the look we're going for. Okay, so now let's move on to management. So what does the evidence suggest as a good kind of first line management for gluteal tendinopathy? Because oftentimes it does fall to a physical therapist. They may come to us first. So what are we thinking for first line management?
Well, it's great if they actually do see a physical therapist first, because then they're actually much more likely to get best first line management, which the evidence suggests is an education and exercise program. A lot of people do still present to their general practitioner, their general medical practitioner, as their first port of call. And first line management in the medical communities are generally some sort of injection. So here it's most commonly a cortisone injection, or it might be something like a PRP injection. But generally injection is seen as the first thing that is provided, because perhaps it'll give them that quick pain relief, and it'll take too long for physical therapy interventions to provide that effect. But the evidence from the LEAP trial was great, because it's something that we can go back to our referring practitioners with and say, well, actually, the education and exercise program showed to be more effective than cortisone in both the short term and the long term. So prior to the LEAP trial, the only study that had some exercise component didn't really show a useful effect until 15 months down the road. And so you can see why general practitioners might be going, right, well, we have to give you some relief in the meantime. But yeah, we've shown that education and exercise can give a really great outcome early, as well as in the longer term. And so that's what the evidence currently suggests should be first-line management.
And why not do both? Like, why not do education and exercise plus a cortisone shot or plus a PRP shot?
So good question. And it's a question that I often get asked when I'm speaking to, medical professionals. Well, we can just do both. And often we'll get referrals from doctors who will do the injection first and then send them to physio. So why not both? Well, firstly, I suppose adding an inferior intervention to a superior intervention is unlikely to improve your outcomes. So we were getting on the LEAP trial, the success rate was around 80%. So we're unlikely to improve that with cortisone. The other negatives, well, there's not evidence for gluteal tendinopathy, but for other similar tendinopathies, for example, lateral elbow tendinopathy. Brooke Coombe and Bilvich and Zeno's work showed that adding the two together actually slowed down the success rate and reduced the success rate over time. So actually they did, not as well when they combined the two together. What are the reasons for that? Well, we know that cortisone has an effect on actually dampening down tenocyte activity. And with our exercise therapy, often what we're trying to do is create some response from those tenocytes. So maybe that's one effect. The other effect that I think we see quite a lot in clinical practice, and also it was interesting in the LEAP trial to see what happened in activity levels in the three groups. So we had three groups, one that did education exercise, one that had a single cortisone injection, and one that was a wait and see group. The wait and see group and the cortisone injection group were both also given a basic pamphlet that told them, some basic education about the condition, no specific load management, but information that reassured them and said, look, it's best in the short term to reduce your activities levels a little bit, let it settle, and then just gradually increase your activity rather than spikes of activity. So they both got that basic piece of information in that handout. Interestingly, looking at the traces of activity level over time, in that first 4 weeks after they were given that advice, the education and exercise group and the wait and see group, they both reduced their activity for that first 4 to 8 weeks. And then we saw this gradual increase in activity levels again. The cortisone group, from baseline to that first 4 to 8 weeks, they actually increased their activity level. And then we saw a drop in activity, and it stayed dropped over time. Now, there weren't significantly, like in terms of statistical significance, they weren't significantly different, but it is something that mirrors what we see in clinical practice. If someone gets given an injection that they get immediate pain relief from, they're much less likely to adhere to load management advice, and they're much less likely to adhere to an exercise program. Not that they are bad patients, but it's just that, if you don't, like, pain's a good motivator.
Always,
so if you have that instantaneous pain relief, then people are busy. They get on with their lives, and they're less likely to, do what they really need to do to make sure they fix this thing for the longer term. And that's why again and again we see with studies on cortisone that we get this short-term fix, but long-term, it tends to recur. And we did see this, and we see it in clinical practice, that, they might be good for a while, but then it recurs. And unfortunately, then patients are often then back to the doctor looking for, a second injection and a third injection,
Yeah.
which, and we know that cortisone can have very adverse effects on soft tissue health. And so the more of those injections they have, the less healthy those tissues become. And then it becomes harder, perhaps, for education and exercise to then have as much of an effect. So for me, I tell my referrers, please don't help by giving a cortisone injection. I would rather just see them with no injections, and we can make a big difference to pain very quickly with those load management techniques that we can provide.
Yeah. And, as you're speaking about the LEAP trial, like you said, a big part of it was education and exercise. Can you share what that education and exercise looked like for the people in the trial?
Sure. And I think it's really important to understand the details of load management programs that are provided, because a lot of the time load management is just thought to be just reducing activity and then increasing it again. And certainly that is an important part of it, controlling overload and gradually increasing load over time, giving the tendons time to sort of adapt. But we also provided very specific advice about reducing potentially provocative positions and tasks that would irritate people. And so these are things that we've already talked about. So, standing. So, for example, standing, hanging on the hip. So slouching onto one side where you're sort of hanging on that iliotibial band. So we encourage people to do less of that. So reduce, time spent hanging, reduce time in sitting spent with your knees crossed. Perhaps, avoid low chairs as much, or don't sit in low chairs as much. Get your bottom a little bit higher if you can. So those are really important elements. Nighttime is incredibly important. These patients experience significant sleep disturbance. And so if we can help them with getting a better sleep, everything feels better, pain levels tend to reduce, they feel much better in themselves. And so it's important, I think, to explain the things that they can do. But if you can actually get them on the bed and go through pillow positioning, it makes a big difference, because I find that if you just tell people something, they'll come back and they'll go, oh, that didn't work. And then go, right, let's go through it. And you put them on the bed, and they weren't doing anything like what you'd actually, describe to them. And so the big things about nighttime are, spending less time lying on the affected side. And so if they can sleep, on their back, but a lot of people will say, I can't sleep on my back. But sometimes you can make it more comfortable on their back by putting a pillow under their knees and just relaxing that lower back a little bit, or just slightly shimmying into like a quarter turn position either way. Or if they lie on their unaffected side, but then we really have to control what's happening with that top leg. And so people say, I've tried a pillow between my legs, but what they might have tried is actually just a little cushion and just between the knees. So the pillow has to be a fairly fat pillow, and it needs to be right from the knees and down along the shins to between the ankles, because we also want to control that external rotation.
Right.
Yeah, or often I find that one of the most comfortable positions is actually that quarter turn position. So, or if you like, halfway between lying on their side and lying on their tummy. So, even lying on their affected side can sometimes be most useful. So they lie on their affected side, straighten out that bottom leg, and then they roll their body halfway towards their tummy, so that they're no longer lying on the greater trochanter. They're actually weight bearing on the anterolateral thigh. And then the other leg is sort of just bent in front. But for people to sustain that, they usually are much better if you get them to wedge a pillow underneath top thigh and their top pillow. And some of them might even need a second pillow to rest their arm on,
or a body pillow.
Yeah, something like that. But that sort of halfway between side lie and prone is often one of the most successful positions. Just make sure with that top leg, it's not right up, near the chest. So it needs to be below the 90 degrees. And then the other thing for sleeping is just also an eggshell mattress overlay can be really useful, because people can't completely control what they do in the nighttime. And if they do end up on that side, they won't wake up quite as quickly, usually, if they have one of those eggshell or waffle sort of overlays on their bed. So those things are really important. And then I think the other important feature of load management is movement training. And so training people around those gait parameters we've already talked about, but simple things like getting in and out of the chair, doing that without having your knees together. So have some space between your knees as you get in and out of the chair, and then going upstairs, because that's a really another really big feature. So using a rail can be helpful, of course, on the side opposite the painful hip, but just even where they place their feet. So often when people are weak in their hip abductors, when they go to stand on one leg to lift the other leg to the next step, the pelvis drops and shifts. And so then they end up putting their foot almost directly in front of their pubic symphysis. So then they are already adducted as they go to try to transfer their weight up the stairs. And that can create quite sharp pain for some people.
Sure.
So even just thinking, feet wider, when you walk up the stairs, pretend you're a cowboy. It doesn't have to be quite that wide, but, just separate those feet and try to minimize the whole side shifting thing. We don't expect people to be rigid in their pelvis, but, think of your legs moving underneath your pelvis rather than your pelvis sort of swinging side to side. So those things, are very important. So I think those components, so the overall load management activity-wise, positional load management, and movement training, I think those are the three really key components of load management.
And, that's obviously a lot of patient education. You don't have to do all of it in the first visit. I would venture to say you'll lose people. Right?
Yeah. So that's where it comes into trying to hone into what is this person's, or what is this individual's major problems, if you like. So what are they having problems with? So patient-specific function. And interestingly, we just published a paper on mediators of the effect of the education and exercise program, and patient-specific function was one of the things that showed to be significant. So if we could improve patient significant function, that seemed to be one of the things that helped mediate the positive effects of the intervention. And so if their big things are, I can't sleep and I can't walk up my stairs. So, focus on those things initially, because if you change those things that are their specific problems, you're most likely to have, the quickest effect.
Right. Yeah, because someone can come in and be like, I sleep fine.
Yeah. Exactly.
I can't walk and it's hard going upstairs. Okay, well, let's see what we can do about that.
Yeah.
So what you're saying is listen to the patient, keep listening to the patient, and tailor the program, and not have like a cookie cutter situation.
Sure. Absolutely.
Yeah, that makes perfect sense. And what about exercise wise? Is there one exercise that's like the savior of all exercises? We used to joke that like the Nordic hamstring fixes everything, right? So that's a joke, by the way. I don't want don't at me on social media and say, how could you say that? It's a joke, but go ahead.
Isn't it all? It's only isometrics, isn't it? No,
I
think we've moved past that now. Only isometrics. Yeah. I don't believe there's one specific exercise, although there's probably one specific exercise that I'd say don't do. And that's usually the clam, mainly because of the action of the clam. If you've got gluteal tendinopathy specifically, if you're lifting that knee up and down and sort of rubbing that iliotibial band over the greater trochanter, that tends to be quite provocative for these tendons. And it's also not arguably the best exercise to target the muscles that we're trying to target and the portions of muscles we're trying to target. So my preference is for strengthening, get weight bearing, get closed chain. And so in the LEAP trial, we did progressions of bridging. So with feet on the ground, activating those glutes and progressing from double leg to offset to single leg bridge. But functional training, I think, is really important. So standing and doing standing squats. And then we go to offset squats. We go to a single leg stance or a single leg squat, stepping up a step. And I think these sorts of exercises have a couple of really important purposes. Well, maybe more. Maybe strengthening, although we showed again with the mediators that it wasn't changes in strength that actually mediated the effects that we had. Perhaps what we're doing is improving motor control, improving play, and sometimes in social media, sometimes motor control is a dirty word, but we're talking about optimizing loading across the tendons. That's what we're trying to do. And so if we can alter someone's gait and alter someone's stair climbing habits, and we know from Kim Allison's PhD research that people with this condition move in ways that actually excessively load these tendons. So if we can train them to move in ways that reduces that tendon load, that can often have a very quick effect, on pain and on function. But the other thing I think with functional exercises is that we are probably improving the patient's confidence to do these things and reducing fear around that. And again, that was one of the other mediators that we showed that was really important. If we improved patients' pain self-efficacy, that was one of the things that improved or that actually created the effect, the positive effect. And so I think that education is important there, but also just doing something that might be scary for the patient, like going up a step, but doing it supervised with a health professional and having them teach you how to do that without actually getting that sharp pain at the side of the hip. That really improves their confidence. They go, oh, I can do those stairs now. So I think, those elements are very important. And then the other main exercises that we did do isometrics. And those isometrics were low load isometrics in supine with a belt around the knees, hip abducted. And then we also did a standing version of that. Again, hips a bit abducted. These are just slow, gentle isometrics without the TFL activating. And again, probably, we might have had an effect just from some people do get pain relief from isometrics. Also, we used it as a recruitment retraining activity. And again, Kim Allison's other research showed that recruitment of these muscles is different in patients with gluteal tendinopathy. And so we did those isometrics. And in my own clinical practice, I find that a lot of patients find that those are helpful for pain, which is interesting. Initially, when patients would give me that feedback, I'd go, oh, yeah, well, that's a little bit crazy. But then we had all the evidence come out about isometrics, and it is certainly not a cure-all, but for some people it really helps. And then from a pure strength perspective or tendon loading perspective, the exercise that we did was a frontal plane exercise. So when they were doing it in the clinic, they did it on a Pilates reformer or a spring-resisted slider. So it's purely standing hip abduction, pushing the legs apart. So just pure frontal plane loading.
I hate that on the reformer. No, I'm just kidding. Actually, I enjoy doing that on the reformer.
It's great. It would be my number one favorite exercise for gluteal tendinopathy and abductor training, because I think it's a way that, because it's weight bearing and we're moving in the plane, the primary plane of action, it seems to just really get the best out of the synergists, if you like. We get a best balance. When you have your foot off the floor strengthening, we seem to see there's a lot of this dominance in the TFL, but put your foot down on the floor, and then we seem to see more, better recruitment in those
Right.
gluteals. And the evidence has suggested that as well. But at home then, because they didn't have reformers and sliders at home, they do that with a band. So it's just a loop of band around the ankles. It's then just a single leg hip abduction.
Mm-hmm.
So into a semi-squat position, and then a single leg abduction. But actually, it's just as much work for the non-moving leg. Actually, that's where they usually fatigue most.
Right.
And so it's really important that they don't sort of hang, on that side. So good control on that supporting leg as they're practicing that frontal plane on the other side.
Right. So you just want to be mindful of not, I call it like popping the hip. So,
Popping the hip.
people like kind of pop the hip out, like you're, putting your hand on your hip and popping it out. So I try to tell people, like, please don't like do a hip pop, try and keep it, pretty neutral as you go in and out. And every time I think of that exercise, even on the reformer, I don't know if you've ever seen that video of like Jean-Claude Van Damme with his feet on two moving trucks, and they start to go out to the side, and he's down in like this, almost like straight across, like split. So every time, yeah. So you don't have to go down that far, is what you're saying. No. Yeah. I always think of that when I think of that movement. I'm like, man, that is really something. So let's talk about, again, how many sessions, right? Because every single country around the world has a different medical system. Some people might, I could say here in the United States, some people might get 5 visits. And I don't even, we have this sort of third party system that someone there you send in your notes and they say, we'll give you 5 visits. And after 5 visits, you have to justify it. And they'll say, oh, we'll give you 2. We'll give you 1, and then you're done, right? So there is a little bit of uncertainty around how many visits someone may be able to have. So, 14 sessions of one-to-one physical therapy might not be able to happen. So what do we do?
Sure. Well, that is the concern, and I guess concern from insurers. Oh, well, this is going to be just way too expensive for us to, fund 14 sessions of physio, which is what we did with the LEAP trial. So they did 1 session a week for the first 2 weeks, and then they did a 6-week block where they had 2 appointments a week, and that was mainly so that they could come in and do that heavy, slow loading on the reformers. But yeah, so is that cost effective? And so in January this year, we just published a paper looking at the cost effectiveness of that education and exercise protocol, comparing that against the cost of the cortisone injection and the wait and see intervention. And what that showed is by looking at health-related quality of life and economic costs together, that the education exercise program was actually the most cost-effective intervention compared to the other 2. So we have to sort of look at it in terms of, how it the cost to the individual and the cost to society. But interestingly, that did show then that it is a cost-effective intervention. So we do now have that evidence to provide to insurers, but it might take time to get some change in that. And so we need to also see, are there ways that we can work with the current system, and can we still get effects with less treatments? We don't have evidence for that at the moment, but actually Bill Vincenzino and Rebecca Meller and I are currently working with Helen French's team in Ireland, and they're looking at the feasibility of providing the intervention in a light version, if you like. And so that's just 6 treatments.
Okay.
And so, yeah, it's going through a feasibility trial at the moment. And if that shows to be feasible, then it would be great to see that progress to a full RCT where we can test it at that, 6 treatments.
Yeah, it's just, gosh, insurance, right? In Australia, things are probably much different. Here in the United States, you never know. Great. So now let's say there's a health professional, a physical therapist physician listening to this, where can they learn more about everything that we talked about today?
Sure. Well, if they want to learn more about the LEAP trial, that paper, the outcomes paper that was published in 2018, was published in the British Medical Journal. The first author was Rebecca Mellor, Mellor. That is an open access paper, and so they can download the paper. Now, there's also a supplement. So if they really want the details, and it's got details of the exercises and all the sets and reps and everything.
Which we love.
Yeah, so that's in the supplement. So you can't just download the paper. So you have to actually download the supplement as well. So there's that paper, which is probably, a go-to. And then if you want to delve deeper into gluteal tendinopathy and other treatments around the hip and pelvis for other conditions, I've got a learning site at dralisongrimaldi.com, and so people can buy specific courses, or I've also got a hip academy for those who love hips or hate hips and want to get better at them. Then there's a hip academy that has a whole heap of resources, and we have live meetings, which is actually a part I love. We have people from all over the world join together and talking about specific topics. So that's great. So we'd love to see you in Hip Academy as well.
Perfect. And for those of you in the United States, certainly if you're in New York City or really anywhere in the United States, and they want to see you live, you're going to be at Gnosis, which is here in New York City, May 13th and 14th, with 2 hip workshops. So one on the 13th and one on the 14th. So you could go to the one on the 13th, the one on the 14th, or both. So I just want to be very clear on that. You could do both. And I will also say you live in Australia, so it's not like you're here all the time.
No, that's right. And I haven't been traveling for a while with COVID.
Right.
So it's exciting to come back and come back to New York. I've only taught in New York once before, and that was a number of years ago now. Pre-COVID. So yeah, I'm very excited to come back to New York. And on the first day, we'll be talking about anterior hip and groin pain. And on the second day, we'll be, diving deep into lateral hip pain, but also buttock pain, which can often be, challenging to diagnose and treat. So we'll be going into all the diagnosis and the management for all those conditions. So anyone who wants to come to one or both days, would love to meet you.
Yes. And we'll have all the information for this, the podcast website at podcast.healthywealthysmart.com. And we'll share it on social media as well. And is all that information also on your website?
Yes.
Perfect.
All the information is on the website.
Perfect. Yeah. So you can go to Dr. Allison, that's Alison, Grimaldi.com. So 1 L, not 2, on the Allison. So I don't want people to get confused. Well, this was great. And one more question before we wrap things up. And it's kind of a question I ask everyone. And knowing where you are now in your life and your career, what advice would you give to your 20-year-old self?
I think the best advice to my young self and to anyone in their early career is really invest in your continuing education. I've been a lifelong learner, and I must have done 20 courses in my first 2 years after I graduated. But you just learn, when you graduate, you're really just at the beginning of that learning journey, and there's so much more to learn. So, jump into practice, but continually, don't think you know everything when you graduate from uni. There's so much more to learn, and even me, plus 30 years down the track, I'm still learning, heaps every day. So, use all the resources you have available to you to keep up to date and continuing your further education, because the more I suppose, the better outcomes you can have. And that just brings so much reward to this amazing profession. And we still see way too many people leaving the profession too early. So it is a wonderful profession, but you'll get more out of it when you put more into it.
I think that's great advice. And I have to tell you, the older I get and the longer I practice, I think it's the less I know. Can that be possible?
Yeah. That's like when you do a PhD, you go into a PhD and you think you're going to answer all these questions and you're going to come out knowing everything. And all you come out with is a lot more questions.
Yeah, exactly. Well, Allison, thank you so much for taking the time out, coming on the podcast today. I really appreciate it. And I look forward to seeing you in New York City.
Perfect. Thanks so much for having me. It's been great.
And everyone, thanks so much for listening. Have a great couple of days and stay healthy, wealthy, and smart.